many birds with one stone. تفضل دكتور مجدي.
شكرا جزيلا أستاذي الغالي دكتور خالد I'd like to thank the Egyptian Society for inviting me to this elegant 40th Congress. And I thank Professor Mohammed Ghanaimat. He illustrated a lot about what I'm going to say this morning. My topic today is about a modern or a recent change in the way we treat our patient. We should not be kidney-centered, diabetic-centered, or cardiac-centered. We need to manage all together in order to get to the best outcome in our patient. So we know that diabetes has a lot to do with cardiorenal diseases. It increases the type 2, 4, and 5 incidence and complications. And we know that there is a link between the kidney and cardiovascular system regarding the risk factors, the pathway to damage, the related biomarkers that will join them together with diabetes also. And there is now what we call nephrocardiology, joining the diagnosis, epidemiology, pathophysiology, prevention, prognosis, risk factor, monitoring and therapy, and systemic disease together. We might think of this as the same entity. It's not different entity. It is associated with increased risk of mortality, all-cause death or cardiovascular death, and it is a lot of cardiorenal complication in patients who develop diabetes when they are young rather than when they are old. And we know that GFR increased cardiovascular mortality, albuminuria increased cardiovascular mortality, and we know that good diabetic control will reduce these cardiorenal outcomes, and we know that also controlling the cardiovascular system and GFR will improve the cardiac outcome. And finally, we can now tell that if we control the left ventricular mass, it will improve the outcome in patients with CKD and will prevent progression to end-stage kidney disease. So how to manage these triple diseases together, hyperglycemia, diabetes, CKD, and kidney disease? We have to tackle and address a lot of metabolic pathways, and we have a lot to treat to prevent the progression of this cardiorenal metabolic disorder. And so we need an interdisciplinary as well as multidisciplinary care models and education. We need to harmonize practice guidelines between nephrologists, cardiologists, and diabetologists. We need to address risk mitigation strategies, and we need self-management program and individualization. To do so, we have to mix our medication between those that treat chronic kidney disease and those to treat hypertension and the treatment of ischemic heart disease as well, together with the anti-diabetic medication that we just heard a lot in the last presentation. Again, this necessitates that we should listen and apply the guidelines, the ADA guideline or other anti-diabetic medication guideline, the KIDUKI guideline and the KIDIGO guideline for chronic kidney disease, guidelines for ischemia, and guidelines for hypertension. To do so, we will need a lot of medication. Patients are taking medication by a spoon, a lot of medications. If we should consider other medication to treat these three diseases. And this necessitates that we need less medication to reach to the target of better survival and better quality of life for our patients. So this is what's about this presentation, how to reach this goal, fewer medication to treat a lot of complication. We have many drugs in our armament, the RAS blockade, the MRAs, Mineralocorticoid, and the ARNI, anti-neprilysin, sodium glucose transport inhibitor, GLP-1 agonist, statins, and among other medications. Let me start with the RAS blockade because it is the cornerstone in treatment of CKD, diabetes, diabetic kidney disease, as well as cardiovascular disease. It plays a very important role. It has a very good organ effect, as well as systemic effect that can protect the heart, control blood pressure, and also protect the kidney and the patient with diabetic kidney disease. And in all randomized study regarding kidney, there is albuminuria reduction and there is slowing progression to end-stage kidney disease. And this is associated also with good blood pressure reduction. And of course, we know that the cardiovascular outcome with these medications are the best. They prevent We have a lot of study preventing left ventricular hypertrophy, arrhythmia, heart failure, and they are very beneficial for the patient with cardiac diseases. And that's why they are #1 medication. This is an ADA 2022 guideline to treat hypertension, either if the patient has CKD or albuminuria, and even if he doesn't have CKD or albuminuria, it is the first line ACEs and ARBs to treat such patient. Also in the KDIGO guideline 2021 for hypertension, they come in the first class preferred drug to treat patient with chronic kidney disease. This is again the European Society of Cardiology 2021, again ACEs and ARBs, ACEs or ARBs to treat patient with diabetes, diabetic kidney disease, cerebrovascular disease, peripheral arterial disease. It is the best medication ever. Another medication is the Mineralocorticoid. We know now that we have the steroidal, MRAs, spironolactone, eplerenone, and the newer one, the dihydropyridine, which is now present as phenyrenone, that will be soon available in our market in Egypt. This reduces the reactive oxygen species, they increase the nitric oxide, they prevent endothelial damage, endothelial dysfunction, and they have very good anti-inflammatory and anti-fibrotic effects. And we know that spironolactone is the best treatment for resistant hypertension, and it can treat heart failure and reduce mortality in such patients. And even if this patient has diabetic kidney disease or chronic kidney disease, the use of spironolactone is beneficial in such group of patients, with the risk, of course, of hyperkalemia. And in the Fidelio DKD study that was published 2020, and the Figaro study 2021, they have shown that it can slow the progression to chronic kidney disease, and they reduce albuminuria as well. And another study, the Fidelity study, the effect of phenyrenone on the heart in patients with diabetic kidney disease and chronic kidney disease, it showed a good protection. The composite cardiovascular outcome is better, especially hospitalization for heart failure, together with less progression to end-stage kidney disease and less albuminuria. So this medication should be prioritized in the treatment of such patients, and according to many reports, it is beneficial for the kidney and the heart. ARNI, neprilysin antagonist, sacubitril valsartan. Again, a very good drug. It induces diuresis, it has effect on sodium homeostasis, vascular integrity, it produces vasodilatation, tissue protection, kidney and heart, and it showed very good effect on the heart, reduce the proliferation and the fibrosis in the left ventricle through blocking neprilysin, and it decreases the N-terminal pro-beta type natriuretic peptide. And also it was examined in patients with CKD, and it shows preservation of GFR or maybe a little bit improvement in GFR. And again, there is a little bit risk of hyperkalemia with such medication, but it should be considered in all these patients. And the anti-diabetic medication, the new anti-diabetic medication, particularly sodium glucose transport inhibitor and GLP-1. We know now that the guidelines is updated every year. This is the ADA, just published in January 2022, establishing that in patients with atherosclerotic cardiovascular disease and high-risk cardiovascular disease patient, and patients with heart failure, and patients with chronic kidney disease, there is preferential use of sodium glucose or GLP-1 according to the comorbidity. And these sodium glucose transport inhibitors have changed the way we look into diabetes and into kidney disease. It started by the EMBAREG in 2015, and then the Canvas 2017, and 2019 was a breakthrough with the Credence, DABA heart failure, Vertis cardiovascular, and the CLEAR-TIMI. And then in the last 2 years, the Emperor reduced, Emperor preserved, and the DABA CKD. This medication has proven effect to prevent fibrosis, induce natriuresis, albuminuria reduction, preservation of the kidney, good glycemic control. It has good effect on weight loss, as well as good effect in the cardiovascular system, sympathetic nervous system, cardio and renal protection. This occurs through several mechanisms. I won't go into the details, but it is good in diabetes because it works extra pancreatic. it improves insulin resistance. In the kidney, it decreases intraglomerular pressure and restores tuberoglomerular feedback. And in the heart, it decreases body weight, decreases blood pressure, improves caloric use by the heart, and it has a positive effect on atrial stiffness. And so the end result is improved cardiorenal hemodynamics and cardiorenal protection. This is a very important group of drugs, and if we revise the studies from the EMBREG down to the EMPEROR, the last one published, there is less worsening of kidney function with all the medication. There is less cardiovascular death and hospitalization of heart failure. And one good benefit just reported by canagliflozin, it reduces hyperkalemia. And this is very good because it will allow us to use RAS blockade, which is necessary in such group of patients. So this group of drugs should be, again, prioritized in all cardiorenal metabolic patients. What about incretins? We have GLP-1 and DDP-4. They have also beneficial effect in the kidney. They reduce tubular basement membrane thickening, less expansion of the mesangial, and less immune cell infiltration with restoration of podocyte and less interstitial fibrosis. And regarding DDP-4, at least they are neutral to the kidney, if not beneficial of the kidney. We know that linagliptin has reduced proteinuria, but they are neutral regarding the kidney disease. They are very safe drugs. They don't induce hypoglycemia, so we can use them clearly. And also regarding the heart, all except saxagliptin have no effect on heart, and there is only increased heart failure with saxagliptin. That's why it's not available anymore, and it's not used anymore. But other drugs are neutral to the heart. We can use them in such patients. GLP is another story. It is cardioprotective through the studies I will show you in the next slides. It has improvement in cardiac function. It improves renal function. It decreases renal inflammation, fibrosis, and proteinuria. And also, it is a very effective anti-hyperglycemic medication, more than DDP-4, more than other medication. It can be compared to insulin. Again, with the difference that it reduces body weight and it has less hypoglycemic effect. Regarding the kidney, it preserves the kidney, less progression to end-stage kidney disease if the patient is macroalbuminuric or not. And also the time for the first event is by far reduced by using dulaglutide, which is the injectable once weekly GLP-1 available in Egypt. This effect on the kidney and in the heart are either direct through modulation of the sodium water homeostasis, improved tuberoglomerular feedback, reduced renal and systemic inflammation, decreased oxidative stress, and reduced renal hypoxia, or indirect through good glycemic control, weight reduction, blood pressure reduction, improved lipid profile, good coronary blood flow, and decreased intestinal lipid uptake. So it has direct and indirect protective effect. That's why the KDIGO guideline 2020 have chosen this group of drug to be used because their effect on the heart as well as on the kidney. They are, again, preferential drug. This is a meta-analysis published last September, revising all the 8 cardiovascular outcome study with GLP-1, and it stated all except lexazinatide in the Alexa have reduced heart failure, all reduced the major adverse cardiovascular event in patients with history of cardiovascular disease and patients without cardiovascular disease. They reduced cardiovascular mortality, they reduced non-fatal MI, non-fatal stroke was reduced, macroalbuminuria significantly reduced, renal endpoint, including progression to end stage, is markedly reduced, and they should be considered for treatment. What about statin? Because statin, again, is a pillar in treatment of such patients. And that's why it is included in the KDIGO guideline 2020. And also in the European Society of Cardiology 2021, patients with CKD, even moderate CKD, are at high risk of cardiovascular morbidity and mortality, and patients with GFR less than 30, again, at very high risk to develop cardiovascular morbidity and mortality. And we have evidence from a meta-analysis, including 170,000 patients, that reduction of LDL will definitely reduce the incidence of heart attack, revascularization, and ischemic stroke. And also we have some report that it may protect progression to end-stage kidney disease. It's not strong, but again, the patient will benefit through saving his life and saving his heart. And statins with ACE inhibitor and sodium glucose are the main medication to reduce cardiovascular risk in patients with cardiorenal metabolic diseases. And we are in the era of approval for different category. We have the canagliflozin, the first sodium glucose transfer inhibitor proven for patients with chronic kidney disease and heart failure, followed by dapagliflozin, approved for patients with CKD, either diabetic or non-diabetic, and also approved to be used in heart failure in diabetic and non-diabetic patients. Empagliflozin is approved for heart failure in diabetic and non-diabetic patients. Finerenone is finally approved for patients with diabetic kidney disease due to type 2 diabetes. And so we now have new therapies to actualize kidney as well as cardiac health that we should use. And now the cornerstone treatment for patients with diabetic kidney disease after risk factor management is the ACE and ARB, sodium glucose transport inhibitor, MRAs, and GLP-1. And in patients with heart failure, this is the fantastic 4 drugs: MRA, ARNI, sodium glucose transport inhibitor, as well as beta blocker. And so we have seen that 3 of them share the protection with the kidney disease. So we should use them together. And if we summarize the benefit of all this medication, we'll find that sodium glucose transport inhibitor come in the first line. It reduces MACE, cardiovascular death, heart failure, hard renal endpoint, albuminuria, as well as all-cause mortality. It is followed by ARBs, statin, GLP-1, and ACE inhibitor. And to conclude, we should prescribe medications that can save the kidney and the heart and the life of the patients. And we have now the armament, we have proper medication. Just 2 minutes. We have proper medication, mainly the 4 major medication I am talking about. And And that's why this is the KIDUKI 2022 commentary on the KIDIGO 2020 clinical practice. They just added ARNI and MRAs in the management of the patient with diabetic kidney disease. And this is a very wise add to the armament we have. And to conclude, now we have a pressing need to create a common workflow model in the cardiorenal metabolic medicine to address the complex need in this very vulnerable patient population with available state-of-the-art interventions that may reduce cardiovascular and kidney risk in this patient. It is imperative now to use and to align physician expertise and workflow to tackle this problem. And we have ACEs, ARB, sodium glucose transport inhibitor, and finerenone. They work by complementary mechanism to protect the kidney and the heart. Future research will further elucidate how to use them together, and kidney care should be now shift from treating to preventing progression of end-stage kidney disease. Thank you very much.
Thank you, Professor Magdy, for this elegant presentation. This is the last presentation in this session. During this session, we revised very important topics as regard post-transplant diabetes, the renal effect of COVID-19 vaccines, and lastly, cardiorenal and metabolic medications. We can open the discussion now if we have any question from the floor. Dr. Ayman Rifai.
Mike, يا جماعة.
Thank you very much for all the speakers. I have a question for Professor Ghunaymat regarding the post-transplant diabetes. I think we manipulate some of the risk factors that are preventable or could be modified. We can reduce the incidence of post-transplant diabetes. When we analyze post-transplant diabetes among our patients, we found, after multivariate analysis, 4 important risk factors: the family history, the obesity, the steroid dose in the first 3 months, and the HCV infection, especially with tacrolimus. So one is not preventable, which is the family history, but we could manipulate the other three. One of the successful strategies that you showed us, but I want to stress on it, is the adoption of steroid avoidance in high-risk patients. High risk, I mean for diabetes, not immunologically high risk, the low-risk patients. Since we adopt this policy, the incidence of post-transplant diabetes dropped from 16% to only 4%. So I think this is very easy to apply such policy in low immunological risk patients to avoid post-transplant. What do you think? Because you said that
Totally agree with
in
you.
your conclusion, you said that this is a conflicting or this is compromise about the adoption of such policy. But I think it is a successful policy.
I totally agree, and I think I showed one study, late 2021, which concluded that post-transplant diabetes with the use of steroids is 42%, and with steroid-free regimen is less than 10%. So I totally agree with you, yes.
Any other question? So I have one question for Professor Ghunaymat about the survival of the graft. Is there any relation between the occurrence of post-transplant diabetes and the control of this state and the graft survival?
So the graft survival is definitely less with the development of post-transplant diabetes. It's reduced by at least 60% over the next 10 years. Unfortunately, معظم الستاديز that we showed هي كلها كانت على 4 و5 و6 سنوات, وبالتالي it's too early to judge on both graft and patient survival. But anyway, it's reduced by less than 60%.
So if we have any question, any other question?
أكيد سؤال عبقري من الأستاذ الدكتور صبري. He is asking about what about the dip of GFR at the start of the use. It is recorded. It's present in almost 30% of patients, and the decline will disappear within the first 4 to 6 weeks after the use. It's exactly what happens with the use of RAS blockade. GFR suddenly drop because there is vasoconstriction, or we stop the vasodilatation of the afferent arteriole. That's why GFR will suddenly drop. Yes, we tell the patient sometime it will, but on the long run, it will preserve the glomeruli, the rest of the glomeruli, and the patient will have better renal survival.
Thank you.
Okay, thank you. If we have any other question, we can have one more question. We don't have any time. Okay, thank you. Thank you very much.